Hello, welcome, and most importantly, congratulations, because you found your way to what I think is going to be one of the most exciting and interactive sessions in the simulation lab, which is the beating heart of PCR London Valves conference. And us as your team, we are delighted to be speaking to you today and guiding you through in this sponsored session from your index procedure through to revalving with a novel self-expanding valve, which is the ACURATE Prime. So who are we and who is your team? Well, let me introduce you. My name's Chris Cook, and I'm going to be your anchor. I have to my right my friend and world authority in revalving considerations, Professor Tarantini.
Thank you.
We have two not rising stars, but risen stars of cardiology. We have Arif and Alessandro, and they have pioneered some of the learning techniques that we're going to see today with regards to simulation. But there is one other really important member of the team, and that is, of course, you. And Arif here is going to be showing you the catch boxes. Please, 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 if it's not clear enough for you, if you want greater understanding or you want something repeated, raise your hands. Will come to you. If needs be, we'll throw to you because we want your interaction. So listen, let's jump straight in, and I want to hand over to the final member of our team. Helga, welcome to the stage, and tell us about the patient that all of us are going to treat together.
Thank you very much. So we're talking today about a 79-year-old male patient, rather obese, as you can see here, 110 kilograms, 184, and the patient complained about dyspnea, New York Heart Association, class 3, and he has a known diffuse coronary artery disease, arterial hypertension, hyperlipoproteinemia, and really important for this case, the ECG shows a left anterior hemiblock and a right bundle branch block. You can see here the coronaries, and there's clearly nothing to improve at the moment. And we see a rather poor quality echo, but nonetheless we can see that we have a aortic stenosis here with a mean gradient of 34 millimeters of mercury, a Vmax of close to 4 meters, and this translates to an aortic valve area of about 0.9 to 1 centimeter squared. Due to this not completely clear picture, we performed an additional MRI, and you can see the measurements here. Importantly, there was a suspected cardiac amyloidosis, but again, the aortic valve proved to be stenotic on the one hand side, as you can see here, and there was some sort of regurgitation as well, with a fraction of 50%. We then went further for the CT measurement, and you can see all the measurements here. On the upper left panel, you can see the parameter-derived annulus of 28.9 millimeters, so a rather large anatomy, and all the other measurements were rather large as well. Importantly, the coronaries, on the right side, no problem, 19 millimeters. On the left side, very low, only 6 millimeters. The aortic valve was severely calcified, as you can see on the lower right panel. We have more than 6,000 units of calcification, which definitely shows that we have a severely calcified aortic valve. The CT showed these femoral arteries. First impression was that it should be no problem to treat the patient with a TAVI device. However, it is severely tortuous, which proved later on that this will be a problem. I have to be honest, I didn't expect that, but after I reviewed the CT once or twice, I had to accept that this is really tortuous. So the aim was to treat this patient with the new ACURATE Prime device, and you can see it's an XL, that means 29 millimeter device. That's a new large device which can treat such large anatomies. You all know the valve. We have these open stabilization arches. We have this supraannular leaflet, which usually yields a very good hemodynamic outcome. What is new, we have connected cells, as you can see on this image here, which give the valve a little bit more radial force and, more important, an equally distributed radial force around the complete circumference. Of course, this valve has an active PV seal, which was there before. So, the idea was to have the right femoral artery as a primary axis, and the secondary axis, the radial artery, right radial artery. Wanted to use a Safari XS wire, the 14 French eye sleeve sheath, and the pre-dilatation with a 25 millimeter balloon, which is a little bit small. We are discussing later on what we changed during the procedure.
Okay, wow. Thank you, Helga. This is complex anatomy, and this is real-world practice. So, you know, we're looking forward to see how the team function on this. So thank you for bringing it to us. Giuseppe, what do you think? What do we need to gain from our index TAVI procedure?
I think what is important in this kind of patient is to get, ideally, no PVL, no pacemaker, and actually to keep open all the possibility for the future, and actually consider if you can go back to the CT scan. I think in the audience it's very important to, recall all the metrics of these patients. Actually, as you can see, we have an ST junction of 37 that is roomy, and it is very important in terms of keeping there the coronary perfusion. And the other point is the height of the left main. So we need to find out what is the compromise. So first of all, we need to orientate the valve. This is very important. But actually considering that the ascending aorta is very wide, we shouldn't have major problem in terms of coronary perfusion and sinus sequestration. So ideally, I think that intention to treat should be 29, orientation in all cases, mainly in this case, and actually try to optimize the depth of implantation to be sure to reduce and to minimize the PVL and pacemaker rate.
Fantastic. So we've got a good summary there. You know, we're aiming here for a really good result, and we've talked about the lack of PVL, things like commissural alignment, accurate depth assessment. Now, is there anyone in the room that wants to think about, in 2024, we need to think about the next procedure as well. So what types of things do we need to make sure that this patient has a sort of lifetime management decided upfront at the index procedure?
Could you launch something?
Can we have the lights up in the room for a little bit?
Let's pick one.
This is the fun bit.
So we will throw this box. I will throw it. Okay?
Yeah.
So
Luca, let's go to Luca.
Where is
There we
Luca?
go.
Luca is there.
Luca. Oh.
Okay, Luca can start. In the meanwhile, Luca, would you go for coronary protection in this case or not? 37 is the ST junction and the left main is low. What is your practice here?
Well, I'm not sure. Okay. So first of all, I will answer to the last question and then I'll go back to the first.
Yeah.
So let's say that when you have 6 millimeters in terms of height, you need, always need to consider additional maneuver in order to make sure that the safety of the procedure is confirmed. So I will definitely evaluate whether during the implantation of the valve, when it's not fully released, whether there is still some flow in the coronary artery. Maybe it was just an option, we can discuss it. Maybe just leaving a catheter there and a wire, and then evaluate afterwards, just before the full deployment. Or with other platforms, maybe you have to do upfront. So we can discuss this step. In some other occasions, maybe you can consider some, let's say, leaflet splitting techniques, but this is not probably the case.
No, it's not.
But definitely for the next procedure, as we mentioned before, in 2024, we need to think about multiple things, of course, but the most important is, if the risk of coronary disease is likely, we need to make sure that the alignment is correct. We need to make sure that we'll have enough room for a second valve, and then we can discuss which type of THV inside. And also, Alternatively, we can need to discuss which type of first valve to implant for the second procedure.
Perfect.
many
Now,
things that,
I assure you that wasn't scripted, okay? But he's come up with all of the key points. We need a great result. We need to be able to re-valve, and we need to have coronary access. So Helga, there's some challenges for you and the team in this case. We really want to see how did things progress.
I can show you the case. Perhaps before I start with the case, I would like to make one more comment on this very excellent points. We decided to go for the ACURATE Prime, and we have these upper crown which holds down the leaflets, and therefore with 6 millimeters I'm not really concerned. That's why we decided not to go for additional safety measures, but rather go pretty straightforward. Actually, I'm lying a little bit. It's not really straightforward, but you can see it in a second.
But that's a nice tip. So whilst the slides are loading, the design of the valve folds back those native leaflets. So low coronary heights is a good indication for the valve.
Okay. Welcome to the hybrid OR of the St. Johannes Hospital in Dortmund in Germany. I'm Helge Möllmann, and I'm glad to assist a little bit during this ACURATE Prime case, which will be performed by Dr. Grothusen. We have the pigtail catheter in place in the ascending aorta. We usually try to pass the aortic valve with the pigtail and only use the implants left in case of difficulties. We have the feeling that this may be a little bit more atraumatic and perhaps decrease the risks of stroke a little bit further. So due to the kinking in the femoral arteries, it's hard to move the pigtail catheter probably. Therefore, we decided to exchange the 7 French sheath against the implantation sheath, which will give us much more stability. Now the valve has been passed. Pigtail is a little bit stuck in the calcium of the aortic valve, so we carefully try to bring it forward. Do you feel the resistance or?
Yes, you can also see that the pigtail is curved in the abdominal aorta, so I'm just waiting that maybe I can get it through.
So heartbeat by heartbeat, it advances a little bit.
Now it's gone over the valve and it's in the left ventricle. So I can take the standard J wire out and replace it with the Safari XS wire.
Now we are really deep in the ventricle with the wire, which is fine. It's always important to have the curve showing to the upside in order to make sure that the wire has its correct position. So here you can see the new ACURATE Prime device. It looks a little bit similar like the valves before, but there is a really important difference. And this is this part here, as you can see here, this diamond is now complete, which gives the valve a much stronger radial force to help reducing paravalvular leak. And it's 29 millimeters, so we can treat a much broader range of patients now, which is fine. So this is the XL Prime. So in the meanwhile, we checked the projections, which were calculated by means of the CT. And we see here the 3-cusp view. It's a little bit difficult to see, and I go back one. Here we have the cusp overlap view, which we will need for the implantation later on. Now it is important to predilate the valve properly. Here we have an annulus of around 28 millimeters. Usually we are trying to pre-dill with a balloon which is just 1 millimeter smaller. So there is no 27 millimeter balloon on the market as far as I know. So here we are using a 25 with a lot of pressure in order to really predilate the lesion properly.
we have a lot of kinking so that you can see that the balloon is entirely gone into the sleeve with nothing left.
Aus. Und aus. So we are not happy with this pre-dilatation. I'm convinced that it's really important to have a proper pre-dilatation. And here we had a lot of movement. That's one problem. The other problem is that the balloon seems a little bit too small for the anatomy. Therefore, we decided to go for another balloon, which is 28 actually, and 60 millimeters long. And I hope this will give us a little bit more stability during the pre-dilatation. Push. Und aus. So we are in the three-cusp view, which is important to know for the alignment. So in the three-cusp view, we have to see all three arches, as you can appreciate here, one in the middle, one on the right, and one on the left side. So we are probably quite well aligned right now. In order to check this, we go to the cusp overlap view, where we would like to have two on the left side of the screen and one on the right side of the screen. And this looks already pretty well. We try to make it a little bit better now, go a little bit deeper with the valve already. I think it's quite well aligned with two arches on the left side, one on the right side. We have additional markers at the bottom of the valve. Due to this really steep angulation of the C-arm, we cannot really see them here. So we are RAO 35, quarter 30, which is really steep. Therefore, we have to rely on the arches in this case. So we have a lot of force on the system. We really have to push hard to bring the valve here. And what we already can see that we have a little bit of parallax. There's this tiny marker which is designed to help us find the exact depth. And you can see it's not a spot, it's a little bit like a circle, which already shows us that we have at the moment in the position like this a little bit of parallax, and we have to take care about this during the release. Nonetheless, we would like to start like this. Again, all three posts can be seen, which is probably a good sign for the alignment. So we are opening knob number 1. The depth is correct here. Can I pace a bit auf 120? Nicht so viel. Ja. Ein bisschen Push raus. Keim. Jetzt ein klein bisschen. Minimal Push, nicht mehr. So now we correct for the parallaxes. You can see that the marker is now a line. We have to push a little bit like this. Yeah. Nicht mehr. And now I released the valve, which goes pretty quick, as you can see here. Just one turn on knob number 2, and the valve is open. For retrieving the delivery system, we are pulling the wire back all the way, which brings up the capsule a little bit. Now we can carefully retrieve the capsule. Now we are free. Now we are back to the three-cast view, as you can see here. The posts are well aligned, one on the left side, one on the right side, one in the middle, which shows us that we have a good alignment of the valve. What I can already see here, that the direction of the posts are not 100% equal, which is always a sign that the valve may not be open completely. For this purpose, we usually like to go to a RAO cranial, very much to the RAO cranial, which allows us to look somehow into the valve. We'll try to do this. A little bit difficult with this patient because we have these extreme angulations. But here you can appreciate this quite well. So here we now look into the valve. And I let it run again, and you can see that we are not completely circular. Therefore, I would recommend in such a situation to be very liberal with the post-dilatation in order to improve the result, and especially the long-term result, even a little bit further. So we place the balloon as deep as possible, of course not too much into the ventricle, in order to avoid too much interaction with the leaflets. Und aus bitte. Here's now the final result. So we have a couple of points. So there is no aortic regurgitation, which is fine. We have complete parallel posts now, which is fine as well, because it shows us that the valve is completely open, probably due to this post-dilatation maneuver. We have a very good hemodynamic. So we are quite happy with this case, and we'll now go on and retrieve all the catheters and close the groin.
So now that's our final view of the puncture side, of the TAVR side, and you can see no bleeding. You can clearly see the bifurcation, so no problem here. You can still recognize the kinking. That proved to be a little bit difficult, but otherwise everything seems fine.
Okay, with that, we're done. Thank you very much for the attention, and bye-bye to London.
Wow, fantastic. Congratulations. That was, you know what I really like about that? That's a real world challenging case. Lots of challenges, tortuosity, low left main, high calcium score. And you didn't edit out the real world steps. That needed multiple pre-dilatations. Okay, and I always think of this from coronary. We always prepare the lesion in coronary, and we routinely post-dilate. And we're beginning to understand the importance of that with transcatheter heart valves. Tell us again the importance and the need to pre-dilate when using this particular valve.
Actually, especially in this valve, you're totally right. It's important to have a proper pre-dilatation. And I was very unhappy with our first two attempts. The balloon was not stable. It jumped up and down a little bit. And both of us were not convinced that we really had a proper opening of the balloon once in a while. So therefore, we decided we have to change something. And the maneuver we then did is take a longer balloon and, of course, a little bit larger balloon. The longer the balloon is, the more stability is in the system. Of course, it takes longer to inflate and deflate, but the importance of a proper pre-dilatation is much higher than the time for the intervention.
But actually, I think that the main concept, I think, also is that the importance of valve optimization. It is not just in a pre-procedural phase, including the ballooning pre-procedural phase, because actually what Helge did is to evaluate in two projections, in different projection, the expansion, the circularity of the valve, and then you have to optimize. This is also the message of the recent trial. So actually we need to fix in our mind that it's not enough just to put the valve there. Pretty much like the coronary stents. We know that now we need to go for imaging and many other things because all is about optimization. And there is no exception also for the TAVI valve.
And we see this, in the balloon expandable world, the double tap phenomenon, the idea that we can't just stop now with the valve being implanted, that's it, gloves off. You know, we now need to optimize. It's the same thinking that we have for coronary, right?
Yeah, exactly.
And we saw some of the additional features from the Prime platform. Obviously, the size of the valve that you selected. We saw the nice routine workflow, hugging the outer curve with your wire, a very stable deployment. I was watching the blood pressures. They seemed completely stable throughout. But you had some useful markers around commissural alignment, which you demonstrated really very well for us, and also the positioning marker. And of course, that extra radial strength to tackle that 6,000 calcium score. So great job to you and the team. Congratulations.
Thank you.
But, you know, we need to go beyond the index valve, don't we? And I can't think of a better person to demystify and explain the concepts and, in many respects, the terminology that we need to upskill in to understand valve in valve, TAV in TAV. So, Giuseppe, the stage is yours.
Okay, thank you, Chris. So let's go through the basic concept of Redo-TAVI. We have really a short time to cover all the aspects, and I'll try to be as simple as possible, but not simpler, because this is really the pillars of what we do in the lab. So just to go through the concepts that we need to be familiar with. Wrist plane, neoskirt are not the same thing. Leaflets overhanging, index THV expansion, orientation. Let's start with the chapter number 1. Wrist plane. Wrist plane means that this is the level below which the passage of the catheter is obstructed to get into the coronary when we go with the second valve into the first valve. So actually, the distinction of all the valves based on the wrist plane is mainly grounded on two things. One is the short frame and the other one is a tall frame. Regardless of intraannular, supraannular leaflet, it doesn't make any sense, because the concept is that if the valve has a tall frame valve, the wrist plane is higher, regardless that the leaflets are intraannular or supraannular. So the next point is that is strictly connected to the wrist plane is the neoskirt. What is the neoskirt? The neoskirt is the tube graft, the cover stent that we create when we pin open the leaflets. And actually, we might have different situation when we decide to go with a short in-tall valve. In this case, for instance, when you go with a short in-tall, but in a higher position, you have a very high and tall neoskirt. In this case, that you go a little bit deeper, actually the neoskirt, the tube graft is shorter, and actually what you see here is the protrusion of the leaflets inside and above the second valve. This is very important, and this is the background to the second slide, the third slide. That is the positioning. Actually, when we decide to go short and tall, different positioning of the second valve means different level of overhanging. That may be 0, that may be, half the way. That means that we have another orifice area that may restrict the effective orifice area, or actually, in case we put the valve very high, we don't have any overhanging. It is easier when we go with a tall in tall, because different position means no overhanging in all cases. So this is very important to keep in mind all these concepts. What about the chapter number 2, commissural alignments? So this is very important because actually you have, in this case, the commissure, it is a tent that might be 30 millimeters, 3 centimeters in height. We need to avoid to stay in front of the coronary. And actually this is the reason why Helge orientate the valve properly to avoid to have the skirt in front of the left main or the right coronary artery. Why is so important? Because thinking at the lifetime strategy, you cannot use even the basilica or other, unicorn or things like that, because if you have the skirt in front of the coronary, you can do anything in terms of coronary perfusion. Finally, what is the most forgiving situation? The most forgiving situation is to have a very wide ascending aorta. And actually, again, the wide ascending aorta means that when you measure this extra space outside of the frame, that we call at this level VTA or VT-STJ, or at this level we call VTC, this is the space that means that we can do like, again, the case of Helge, we don't need to protect the coronary artery because for sure is there the perfusion, and actually this is two, let's say, limits that we have to consider. This is not working anymore, but anyway, you know, the upper part of the slide, when it's more than 4 millimeters, this is very, you know, forgiving. So you don't need to have major concern. On the contrary, when you are below 2, might be dangerous. In between, there are gray zones. It depends on the size of the second valve because the first valve can expand a little bit more, and we have to consider that. So going to the conclusion, with this specific valve, we have this new concept that I like to share with you. Leaflet-free extra space. That means that if you look at these leaflets do not hit the frame. This is very important because when you calculate the VTA, you don't have to do what we used to do with a surgical valve because this is another animal. Actually, you need to measure the distance between the maximal excursion of the leaflets and the aorta. So actually, it's more forgiving because based on STS junction, this space might be 1 millimeter up to 2.5. That is pretty much important in terms of reperfusion. So concluding, so we need to be multivariate to success. Multivariate means that you cannot trust just on one CT scan, you cannot trust just on a matrix or one valve, the first valve. I'll show you an example of our registry. It is the only registry that we're running, you know, in Europe. It is active. We have already enrolled 85 patients. So a lot of patients, a lot of data, core lab, etc. This is a very interesting case. Failure of Evolut Pro 29 and aortic regurgitation was the mechanism of failure. Actually, by the CT scan, we didn't have the matrix of the first CT scan. But actually, at the CT scan, here the number were like that. 21.7, 21.5 at the level of the waist, and 30, pardon, I don't see very well, 21, because I don't have the glass, but 21 at the level of the upper part. So actually, the operator decided to go with a 23, thank you. Thank you. So with a 23 valve, with a Sapien 23 valve. And actually what happened is that the valve migrates towards the ventricle because the size was not appropriate. And why it was not appropriate? Because we know that the core valve 29 means 29 at the inflow and 23 at the waist. But actually, if you look here, I don't have the laser, but it is important to see here that you have a huge space here. And when you post-dilate, actually you have an expansion of the frame of the valve. And actually this was the reason why at the second attempt they need to go with a 26 into this one. Thank you for your attention.
Thank you so much. So look, there are concepts that we need to upskill in. Okay, we have to do that learning. And the registry that Giuseppe points to is the Bible. So you download it, you read it, and things can become more predictable. It should not be guesswork, but we still are learning as a community. Now, Alessandro, can you reinforce some of those learning points for us and take us through the next piece of learning?
Of course. So what we're going to do right now is we're going to take all these concepts that Giuseppe explained very well to us, and we're going to apply them to the analysis of the CT scan of our patient. But before even we start, I want to tell you that you're not going to see classical CT scan images. You're going to see something more, something different, like a glimpse into the future of this kind of planning, which is made with a software called Mimics that acquires CT images and provides 3D reconstruction. So let's start the analysis. First of all, now we need to focus on the key landmarks of our valve that are relevant for second valve sizing and positioning. So let's start by looking at this lower part of the ACURATE prime valve, which is the lower frame of the valve, which is in contact with the anatomy, it touches the LVOT, the annulus, the leaflets of the first valve. So here, we need to obtain two key measurements, the diameter and the area at two levels. First is the level of node 1, which is here. And remember, this valve is an ACURATE prime XL, so it means that here, normally, on the bench, it has a diameter of 32 millimeters. Okay, while at this level here is the second key level, the bottom of the upper crown. This valve normally here measures 29 millimeters. So this measurement is confirmed in CT. So actually the valve has a diameter here of 29 millimeters, but here it is 28 because it's interacting with the anatomy. Do you remember the annulus was 28? So it conforms to the anatomy. So these are the key two measurements that we need to understand the sizing of the second valve. So we're going to go for a sapien valve, and in this case, a 29 millimeter sapien would fit. Now the second step is we have to understand where to position this valve. Actually, we have two possible options here. One is, let me do it with another color. So one is here, at the level of the top of the upper crown. We need to position the outflow of the sapien at this level. And another position is here at the bottom of the commissural post. And why this is relevant? It's absolutely important because it will determine the height of your neoskirt. So if you implant here, your neoskirt will extend up to here. If you implant here, it will be higher. So you will get the higher neoskirt. And so this will define the so-called neoskirt plane. Now the next step is to understand where are the coronary arteries. You have two images here. The one on the left of the screen isolates the right coronary artery here, and the one on the right isolates the left coronary artery here. So what I marked for you with dots, the white dots are the ostia of the coronary arteries. What you want to know right now is where is the position of the lowest coronary ostium, and this is going to be your coronary risk plane. Okay? So this is essential to then understand the relationship with the next valve that we're going to put in, and let's simulate an implant at the highest position possible. So this valve is implanted, the sapien valve is implanted inside at the bottom of the commissural post here, and this level here defines the neoskirt plane, which is, as you can clearly see, above the coronary risk plane in both cases. So, and it is also, as you can see, almost at the level of the sinotubular junction here. So this means that in this condition, there might be a threat to the coronary arteries. We need to assess another parameter, as Giuseppe showed us, the VTA. So we have to measure the distance in between the aortic wall and the valve itself at the level of the neoskirt. So in this case, we will do it here for the right coronary artery, and in this case, it was 10 millimeters. And here we will do it for the left coronary artery, and in this case it was 8 millimeters. So well above the cutoff of 4 millimeters that we have set before. So this means no risk of coronary obstruction in this case. Also, probably coronary access could be feasible in this case, but we can discuss about that. So let's try also to assess what happens if we implant in a lower position. So we are going to go this time with the outflow of the sapien valve at the level of the top of the upper crown. So our neoskirt plane is now here. Neoskirt plane. It is again above the right coronary ostium, slightly at the level of the left. So in this case, again, we have to assess the VTA distance, but look carefully here, we are well below the level of the sinotubular junction. So this is a situation like Giuseppe described before, like with a wide aorta, that is the most forgiving situation we can have, and actually in this case there is plenty of room for the blood to flow here to the coronary arteries, and we measure that the VTA here is 11 millimeter and here 10 millimeters. It is almost corresponding to the VTC here at this level. So even in this case, no risk of coronary obstruction and probably even an easier coronary access.
Fantastic. I never think they get enough applause when people do smart screens, so I think that's really good. And you know, just to recap, that is our actual patient. So our actual patient has the full range of options left available to them. And look, when you go back to your centers, you don't need to have these lovely 3D reconstructions. You can play around with your own CT analysis software, but start thinking like Giuseppe, like Alessandro is doing in terms of thinking about revalving and have a play and discover yourself. Okay, Arif, you've been very quiet this whole session, but I think now is your time to shine, because our patient, Helga's patient, has had many years of high quality life, but unfortunately his valve has begun to degenerate. And we now need to think exactly about that revalving situation. So you're about to start your case. You're the first operator here. Take us all with you and tell us what's happening next.
Great. So first of all, thank you for allowing me to go from a fellow to becoming a first operator. So we're going to show you something in a true PCR spirit, which is that of simulation. What simulation really allows us to do is to simulate scenarios you cannot do in vivo, you cannot do in real life. All we have is exactly the same patient that you saw the live case from, you saw the analysis from Alessandro, and we're going to put it all together and actually show you how it would look if this patient needed a Redo-TAVI. Because I was the first operator, we have perfectly implanted the second valve. What we've done is we've taken a sapien, according to the size that Alessandro picked, and we've put it in the low position. So just to recap, low position meant that the outflow of the sapien is aligned to the upper crowns. We've already done that, and here you can see is the result. So what you're seeing at the moment is a camera image taken from the outside of the simulator in a sort of left cusp isolation view. So there's a few things which I want to point out on the screen. If you could just pass me the pointer, and
Yeah,
then
let me
we'll
find
just,
it.
we'll
The
just point
laser
out.
was
The
a
first thing
little
is, if you
temperamental.
look overall at the valve geometry, the assembled valve complex, and this really is a concept that we start to talk about when you think about Redo-TAVI. When you put one valve inside the other, what's the final geometry of what I have assembled? Actually, when you're working with the sapien and the ACURATE, if you just walked into this session right now, you wouldn't know if this was native TAVI or whether this was Redo-TAVI. So you've almost preserved the overall geometry of the valve complex that you have. And that just shows that these two valve combinations, the ACURATE with the balloon expandable valve, you preserve your pretty much external geometry in relation to the external aorta. So that's the first thing I want to point out. The second thing, you can probably just see, those of you with a keen eye, there's a little flicking of the leaflets over here. So there's, and the other thing is you see the upper crown of the ACURATE Neo, that's just there. Just in between each upper crown, you can see a little spike there. That shadow that you're seeing is the outflow of the sapien. And that's where our Redo-TAVI procedure has been landed, exactly at that level in the low position. But now let's take a dive inside and show you what normally can't be shown. So this is on the inside. This is a bird's eye view. You're looking down exactly at this assembled Redo-TAV complex. I'm going to show you a few different features. The first thing I want you to note is look at the leaflets that are working. The leaflets that are working is the sapien valve on the inside. It's competent, it looks well expanded, I think you'd agree, and it's clearly opening and closing very well. So functionally, for this patient, in this Redo-TAVI combination, you have a working and a competent valve that's well expanded, because that's really the first thing that we want to achieve, is a working system inside. So there you see that. Then the next thing to point out, let's go even deeper inside of this valve frame complex. Now those of you who would be familiar with these balloon expandable valves, you'd know that the top layer, the top cell, is open cell. So it should be open, you should be able to go through it, but you can see here that's not the case. If I just orientate this a little bit and we come down here, just look there at that top cell of the sapien. You can see how it's closed off. And what is it closed off by? The pinned up leaflets of the first valve. And that is what Giuseppe was describing as the leaflet neoskirt. So just have a look at this again, because you've heard about the phrase leaflet neoskirt, you've heard it described. This in reality is what it really looks like, that these top row of the sapien cells are being covered up by the pinned up leaflet. So that's leaflet neoskirt. What else can we see? Well, we talked about the relationship in the gap you were talking about, Giuseppe, the gap and how much space we have. Well, we can have a look at that here. So let's come all the way up. Let's see how much gap we have. One of the benefits you see of the ACURATE Neo is this exact gap. You mentioned very nicely this space that you have, 1 to 2.5 millimeters. Well, you can see that right here. You see that's little thing that's pushing out is a sapien outflow. And there is this gap in the structure that you're seeing at about 11 o'clock on your screen is a sinotubular junction. You're seeing this little gap, which probably I could fit this catheter through.
Plenty of room, huh?
And there's lots of room. So that's one of the advantages combining these two valve platforms. You're preserving a lot of this very crucial bottleneck space that may compromise coronary flow. And then the last thing just to show you is we come all the way up. We've put the sapien in the low position, and therefore we've created leaflet overhang. And this is what leaflet overhang looks like. The first leaflets are above the second valve, and they're sort of fluttering a little bit. Now, a common question, and Giuseppe, maybe you can tell us about, does leaflet overhang matter? Do we know if leaflet overhang matters?
Yeah, I think that is nobody knows the answer because we don't have long-term follow-up. But what is very important, I think, to highlight for the audience is the following: that even though the second valve is in a low position, actually the leaflets of the first valve are fully open. That means that sometimes, even though you have a restenosis, for instance with the ACURATE, actually you don't need to target necessarily, the top part of the commissure, because actually if you go down, you can keep the leaflets anyway open, and you can, let's say, be less risky for coronary cannulation, coronary perfusion. So this is something, it's an amazing, demonstration of the fact that you don't need to be very high with the second implantation. I think this is the most important part.
Yeah, so we've hopefully convinced you that putting the sapien in the low position will preserve coronary access and avoid that. But now let's prove it. So let's show you live right now if we can access the coronary arteries. So Alessandro, why don't you take us through that and see if you can do that for us now?
Okay, for sure. So maybe, we're gonna get a better view of the aorta. Okay, I'm there with the JL catheter. I won't tell you which sites. I have a J wire. I go in the ascending aorta. I advance my catheter, and I have two options here actually. I will try to go from the inside of the valve. And that's very easy.
Not bad. Where did you train, Alessandro? So you can see that what we've achieved here, you're still semi-selective.
Oh,
Don't call me a perfectionist, but I think you're not quite there. We go.
Voilà.
Well done.
Yeah.
Well done for the cannulation. So that, I was keeping an eye on the timer. That was within 10, 15 seconds. So not bad. They trained you well.
But let me tell you one thing. Guess which sides of catheter is this JL?
So hands up if you think it's a JL4. 1. Hands up if you think it's a JL5.
Well, actually...
Hands up if you think it's a JL6. What's that?
Yeah.
Okay, good. So some of you, what's going on? Why are we
Actually,
oversizing?
It's a JL6. And I think the beauty of that is that you can clearly see it, that it has a very vertical approach, and it leads you really straight to that opening that Giuseppe and Arif showed you clearly, that this valve is preserving this the access to the coronary sinus, and with this kind of catheter, with this kind of curve, you can actually dive from above directly in that space.
And actually, if we can just switch over to the PowerPoint slides over there, please. I just want to show you something. So, because this is something that a lot of people get confused about, because conventionally we're taught to downsize our catheters with tall frame valves because we have left space in the aorta. But it just highlights that we all, as a community, and there is no right or wrong answer. Giuseppe, you've done the Align Access trial and study. You've done most of these cannulations. We sometimes have to be a little bit creative with how we think. If you look at the ACURATE with the balloon expandable valve system, all of your challenges, all of your barriers, all of your leaflets, everything is kind of in this central portion. I like to think of it and describe it as a tornado. And you want to avoid this tornado inside of the middle. And if you do and bring your catheters in a conventional approach, like a Judkins Wright, a catheter that needs to be rotated, you're coming down and then you're rotating, you're going to enter all of these leaflets. So is there a way to come from above and try to avoid all of that central portion? And we've done lots of bench testings and spent many weekends, too many years of my life, doing and trying all different catheters with all different configurations. And ultimately we found that if we were to oversize a Judkins left catheter, you would end up getting much more selective, quickly feasible coronary access, as you nicely demonstrated. And I think you can probably see side by side those two images. Number one, fluoroscopy on that side, and here you can see your catheter has avoided the middle of the valve. And it's not just the first valve, there's also a second valve in there, so you've really managed to avoid all the problems by using this approach. But maybe let's just switch completely back to simulation. Let's pull the catheter back, and let's illustrate now neoskirt and leaflet overhang. You've seen them. Let's see how they can be a problem now. So let's go back. Let's switch, and let's come inside. So you can see again here, we've got the two valves. Catheters coming in. Now,
it always wants to go,
we'll bring the catheter down.
Please be careful because you need to redeem your image after the first failure.
Yeah.
So it's
Okay.
So
easy.
he can't help himself but cannulate, but that's not the aim here. So there we go.
But this is a 3D motion that you're doing, right?
Perfect.
We work in 2D in the cath lab.
Yeah. So here we go. I'm stuck against the neoskirt, and if I was looking at this in fluoroscopy, probably I would think that, okay, you know, that is a top row of the sapien is an open cell design, but actually no, it's the leaflet of the first valve is completely blocking and sealing the access to the coronary sinus from the inside.
Just
So here
rotate a
I'm
little bit clockwise for me,
completely stuck.
if you can. There, perfect. So you see that open cell of the sapien? That should be accessible. That's always accessible. The open cell of the sapien is not a barrier. And on fluoro, it would look completely fine. But you can see here exactly. Let me just adjust this a little bit. Perfect there. You can see how he can't get through that top open cell of the sapien. That is leaflet neoskirt.
Yeah.
And that's how leaflet neoskirt can be a problem. But the question, obviously, and I think you alluded to it, Giuseppe, if that leaflet neoskirt is a barrier there, can we do something about it? Leaflet modification. And that's where basilica can come in. You can create a parting in that leaflet neoskirt and open it up.
Yeah.
And that should solve the problem always, no?
Not always.
Why not?
No, why not? Because actually basilica is not always reproducible in terms of results, because the cutting that you have to do is, really at the base of the leaflets, because you need to create a triangle. If you don't create a triangle and you create just a split, actually it won't change anything. And the second aspect is the importance of the orientation of the prosthesis staying there, because actually in that case, even with basilica or the electro-based cutter or mechanical-based cutter, you can't do anything. But let me say something, 10 seconds. Just this is a kind of glimpse into the future that for me is not the future, but will be the way we're going to treat this patient. Actually, I think that the second valve, the short valve, should stay low in all cases. I'll tell you why. Because you can modify the leaflets at the second attempts without having any shock. Because sometimes when you go with the basilica, you can tear the leaflets, so you have a cardiogenic shock. But actually, if you put the valve down and then you cut with the mechanical base or other things, you can improve the effective orifice area without threatening the patient at the first, before implanting the second valve. Do you understand
Yeah,
what I mean?
that's very neat. I mean, so PCR
So
London
this might
Valves
be the future, I think.
2025 will show you that. But that's a great point.
And there's one thing I also want to pick up on, which is actually completely relevant to how you treated the patient, Helga, is, Arif, we can't do leaflet splitting or modification if we're not commissurally aligned.
Absolutely.
Right?
Yeah.
So by commissural aligning with the platform, with the markers, you've given your patient every option available to them. Okay, so you can't do leaflet modification if you have a commissural post in front of the ostium of the coronary.
Exactly.
Yeah.
Perfect. And the last thing now, just to demonstrate, we've shown you leaflet neoskirt. Now let's show you leaflet overhang and how that can interfere with your catheter. So we're coming down. Again, remember, you don't see any of these leaflets on fluoroscopy, and that's part of the challenge of coronary access. So as we're coming down here, we'll try to get into the thing, and there you can see, as you just pull up with this catheter, that's the leaflets of the sapien you're interacting with. Now you're interacting in the neoskirt. Now you're sort of getting in towards the leaflet overhang just there. Oh, just there. But this leaflet overhang has also at the same time created a space, like a ramp, for your catheters to go down. So it's just having that awareness. And I think this is probably, if I had to have one single take-home message, is you should just be aware the things that you don't see on fluoroscopy when it comes to coronary access. That's a simple thing, particularly with a supraannular valve platform. There are things there that you won't see, and you just need to be aware of this.
That's such a good point, because we can't see anything above that metal stent frame, okay? But the flip side is that when you do your revalving with the balloon expandable, those matching the metal on metal on fluoroscopy is actually really quite simple, and when you're performing these.
Yeah.
All right, another round of applause. Well done. Very good. Very good. Okay, Giuseppe, we've covered a lot of ground, huh? We've gone from index procedure. We've seen probably one of the first, I would think, XL ACURATE primes recorded case. The fantastic result.
Yeah.
You take over now. Tell us what else we've learned and some concluding marks for the session.
One slide, I just pick one slide, my last slide. to make the conclusion. So, as stated at the very beginning of this session by our anchorman, actually the key learnings of this session is from index procedure to revolving with ACURATE prime. So the index procedure is the foundation of the success. I think this is a clear statement that we need to keep in mind, that the first cut remain the deepest. So this is the main message, but actually precision matters. So achieving optimal outcomes during initial implant is essential in terms of PVL, pacemaker, ensure precise commissural alignment. That's, Elge did perfectly during the live in the box case. Unmatched access. The ACURATE Neo Prime stands out with the large cell design is about 2 centimeters, and orientability offering one of the best coronary access among the tall frame valves. What about the lifetime strategy? Build a strong base for long-term care, and future Redo-TAVI means that you need to be very thorough in the planning, considering a thorough evaluation of CT imaging, precise THV choice, sizing and optimal positioning, and tackle challenges like neoskirt. We've seen perfectly with Arif by simulation inside, with all the simulation insights, valve-in-valve placement, leafless overhang to secure future success. I think it has been an amazing session. Thank you to all of you for attending this session.
Thank you very much.